Hi, this is Benedict again. Today I'm going to talk about the impact of inequalities in maternal and reproductive health on health systems and development. Equity in health and health systems efficiency are closely linked. To strengthen health systems, equity needs to be integrated as a component of both outcome and impact. As the inequality in sexual and reproductive health within a country widens, people of high socioeconomic status continue to improve their health, but the sexual and reproductive health of people with low socioeconomic status worsen. In certain instances, this may lead to an overall improvement in health, as measured by aggregate country-level health indicators, meaning that, yes, per average it is getting better, but for many women it is still getting worse. Such an improvement is not sustainable, and at some point may level off. If the health systems and political structures continue to foster increasing inequality in sexual and reproductive health, the overall efficiency of the health system will begin to decline. As certain population subgroups suffer from a disproportionately high burden of ill health and death, the health of the entire population, and in some instances, the health gains of the most advantaged groups will also be affected. Therefore, monitoring and addressing inequities in sexual and reproductive health and rights over time by appropriate policies, programs, and practices is critical. Failing to monitor these disparities could lead to deterioration or breakdown of the entire health system and reverse the progress made in the area of sexual and reproductive health and rights. There has been widespread recognition that health policies for reducing the unequal burden of disease and ill health is an important challenge, not only because health is a source of individual freedom and capability, but also because population health is a determinant of a strong economy. In the final years of the 19th century and in the first years of the 20th century, the Nordic countries introduced the first social insurance laws, bringing health issues to the political forefront. The large social inequalities and the social determinants of child mortality were again addressed in the 1930s in Sweden. And in the 1990s, the persisting social gradient in health was a major issue in national health policy documents in Denmark, Sweden, Norway, and Finland. For example, a case study of 19th century Stockholm, the capital of Sweden, showed that child mortality rates back then were not that different from those of low-income countries today. And there are obvious similarities in the living conditions of the majority of the population in 19th century Stockholm and the living conditions of the population in urban slums in low-income countries today. Efforts made through the social welfare policies in the Nordic states have undoubtedly resulted in lowering health inequalities, improved health, life, and well-being of the Nordic population, and in absolute terms, the overall public health experience of the Nordic countries have been successful, as seen over the past century. So why is this? Well, first, the Nordic countries outperform other countries in terms of poverty differentials, enjoying the possible benefits of having a relatively equal income distribution. It is reasonable to assume that these differentials have an impact on health. The high life expectancy and very low maternal and child mortality rates is one such evidence. Secondly, the social insurance program in the Nordic welfare states and their link to low mortality rates suggest that universalistic programs have a beneficial effect on health. Thirdly, as late industrializers, the Nordic countries were quite poor when they began to implement social and health policies. It is believed that certain important societal characteristics facilitated the implementation of policies to improve health and living conditions. And lastly, economic growth alone is not enough. The welfare policy had a universal basis, although some targeted interventions were implemented to reach lower social classes. This combination largely contributed to lowering health inequalities in the population. So as we can see, we can learn from the Nordic experience that designing and implementing effective policies, strategies, interventions, and programs can improve equitable access, reduce inequalities, and create fairness and social justice in sexual and reproductive health and rights, which is good for everybody.